So what is the mechanism of production of the heart sounds? People might think it is the actual act of closure and opening of the valves that really make up the sound. That is not correct. The exact mechanism of production is because of vibration of the cardiohemic system consequent to closing of the valves. So if the AV valves close, you get a sound, what we are going to call it as a first heart sound. If the semilunar valves close, we get a sound calling a second heart sound. We will go into the details of it. Suffice it for you to remember that the exact mechanism of heart sounds is not the actual act of closure of the sound of the leaflets, but a consequence of the closure of the leaflets. Some problem, yeah, okay. So this vibration of the cardiohemic system, it causes these sounds. But for the sounds to be, their pitch and frequency will be modified by the structural integrity of the leaflets. And the intensity is also influenced not only by the cardiac factors, but also by the non-cardiac factors. So when you're describing a heart sound, you describe various things, including the intensity. What do we mean by intensity? Is it loud, first heart sound, or a loud second heart sound, or is it a soft heart sound? So this intensity of the heart sounds is not only influenced by the cardiac factors, which we are going to discuss in the subsequent. These slides are automatically moving. I do not know why. So this intensity of the sounds is not only related to the cardiac factors, which we will come to it later with each heart sound, but is also influenced by the extra cardiac factors. For example, the thicker the chest wall, the less intense will be the heart sound. And if there is an interposition of a lung, like in obstructive airway disease, then the intensity of the sound also will be much less comparatively, as compared to those people whose lungs are normally expanded. It is also influenced by the mediastinal structures and mediastinal position. Suppose if there is some sort of a deviation of the mediastinal structures consequent to kyphoscoliosis, some of the sounds which otherwise are normal can be heard as very loud sounds. For example, in patients who have got a pectus excavatum, wherein the anterior-posterior diameter of the chest is markedly less, the pulmonic second sound, which is normal in intensity, can be heard as a loud P2, and one is likely to make a diagnosis of pulmonary hypertension mistakenly. So you have to take into consideration not only the cardiac factors, but also the extra cardiac factors, which influence the intensity of the sounds. In hyperinflated lungs and emphysema and obstructive airway disease, certainly can modify the intensity. And in conditions like pectus excavatum, wherein the anterior-posterior diameter of the chest is decreased, a normal sound, normal intensity sound might appear as a very loud sound. And classically, the P2, which otherwise is normal, will be heard as a very loud P2. And there's a very high possibility of making a mistake that the patient might be having pulmonary hypertension because P2 is loud and is audible elsewhere also. So there are some, you need to consider the extra cardiac factors contributing to the interpretation of the intensity of the heart sounds. Can I have the next slide? Next slide, please. Yeah, okay. So in the, no, yeah, right. Stay there only. Now, when you're describing a sound, you should describe not only the intensity of the sound, the timing of the sound, but you should also say whether it is a high-pitched sound or a low-pitched sound. Quite often among the students, there is a confusion on what to call high pitch, what to call a low pitch. The pitch is influenced by the frequency of the sound waves. But obviously, you cannot measure the frequency of the sound at the bedside. So the simpler way of telling it, I tell my students that if you tap a metal, it makes a very sharp noise. That sharp noise is what we call high-pitched sound. On the contrary, if you tap a wood, it makes a dull noise. That dull noise is low pitch. So it is important to know whether the heart sound or extra sound or a normal sound, is it a high-pitched sound or is it a low-pitched sound? This has got some implications as we go along. So the pitch is to say whether it is a sharp sound or a dull sound. That really, sharp sound is high pitch and dull sound is low pitch. It's also important to know where the sounds are best heard. That is the location of the sound, where it is heard with maximum intensity. Why it is important? Because it does help to determine the origin of the sound. Suppose if it is heard best at the apical region, then that even produced at the mitral area are better heard at the apex. That's why apex is called a mitral area. Same way for tricuspid events, they are better heard at the lower end of the sternum, especially on the left side. Aortic area, as you know, it is on the right second interspace, and pulmonary area is the left second interspace. So you have to know where exactly is the sound originating by knowing where it is heard with maximum intensity. So once you know what is the timing and cycle is also important. Heart sound. Is it a systolic sound or is it a diastolic sound? If it is coming between the first sound and the second sound, that is the systole, duration of systole. Normally, duration of systole is shorter and duration of diastole is longer. For example, at a heart rate of 72 beats per minute, the duration of systole is about 0.3 of a second, and the duration of diastole is about 0.5 of a second. That is 300 milliseconds is the duration of systole, and 500 milliseconds is the duration of diastole. So if the sound is heard between the first and second sound interval, then we say it is systolic. If the sound is heard between the second sound and the next first start sound, we say it is diastolic. Even when you are hearing it in systole, you have to know whether it is heard early in the systole or in the mid systole or late systole. These are all important as we go along. And finally, you should also make sure whether the sound is stable and fixed at one point, or is it moving with various maneuvers? Is it moving with posture, change of posture from a recumbent posture to an upright posture, which causes decrease in the preload, so it does affect the right-sided events much more than the left-sided events. Same way, what is the response to respiration? Inspiration causes an increase in the venous return and causes increase in the ejection time of the right ventricle. Whereas in inspiration, there is expansion of the lungs, so the pulmonary vasculature capacity also increases. So a lot of blood is held back within the pulmonary vasculature and less blood reaches the left side of the heart. So there is separation of the what we call left and right events. One event becomes longer, other event becomes shorter. For example, during inspiration, the ejection time on the right side becomes longer and the ejection time on the left side becomes shorter. So this can be taken into consideration when you're trying to interpret where the sound is coming from. Can I have the next slide? Okay. So in describing the heart sounds, here are all the things you take. Timing of the sound. Is it a systolic or diastolic? Is it high pitch or low pitch? Where is it best heard within the pericardium? What is the intensity? Is it loud or soft? Then finally, is it varying with the respiration? Is it varying with posture? Is it varying with squatting? Or what are the changes in Valsalva maneuver? These are all the issues that one should consider. Can I have the next slide? It is also important to remember that the acoustic spectrum, that is the audible range of the sound, varies from 20 cycles per second to 20,000 cycles per second, also called hertz. So if the sound is less than 20 cycles per second, it is not at all audible. And if the sound is more than 20,000 cycles per second, it becomes what we call supersonic. So there also you cannot hear it. So there are some sounds which I'll tell you as we go along. that they are such a low frequency, like 10 to 15 cycles per second. Those sounds are better palpable than audible. Classically, we say third art sound is a very low pitched sound with a frequency range anywhere between 10 to 20 cycles per second. Fourth art sound is also a low frequency sound. There also, again, the pitch is only about 20 to 25 cycles per second. Those sounds which are low pitched or low acoustic spectrums, they are better palpable rather than audible. This is important to remember. So some of the sounds are better palpable rather than audible. And with increasing aging, that is, increasing years in your lifetime, you lose mostly the high frequency sound and less for the low frequency sound. So you're likely to miss out early diastolic murmur of AR rather than a mitral mid-diastolic murmur of a mitral stenosis. So these are all the factors you should take into consideration. And what is the acoustic resolution of the human ear? That means resolution means the ability to discriminate two sounds which are close to each other. For example, A2, P2. Unless the interval between these two sounds is at least 40 milliseconds, most of the normal people will not be able to hear the split of the second sound at all. So you need to consider not only the patient factor, but also the doctor's factors into consideration during the interpretation of the sounds and murmurs. Can I have the next slide? So heart sounds, what we are going to discuss today is normal sounds, that is first sound, second sound. Third sound is normal in young children, but abnormal in adults. Fourth heart sound is normal in very elderly, but abnormal in the younger age group. And abnormal sounds are clicks, systolic clicks, which can be valvular, vascular, and pseudosystolic clicks, pacemaker clicks, clicks of aneurysms of interventricular septum, clicks of aneurysms of the interatrial septum. These are all the things. Diastolic sounds, which are low frequency ones, is S3 and S4. Whereas opening snap is a diastolic, early diastolic sound, is a high pitched sound. Pericardial knot, which resembles more like a third sound, but is slightly higher pitched than the third art sound. So it is better audible than palpable, in contrast to third art sound, which is better palpable than audible. Then we have also got some special sounds which occur in congenital heart diseases like PDA, called eddy sounds, which I will describe to you later. And of course, the presence of a prosthetic heart valves in many of these patients who have undergone valve replacements. Also, you need to know how they make the noises. So first, let us take up the first heart sound. First heart sound is related to closure of the atrioventricular valves. It is important to remember most of the events that occur on the left side, the left-sided events close first, and the right-sided events open first. This is the fundamental rule. So M1, so the mitral valve closes earlier than the tricuspid valve. So first heart sound is composed of two components, mitral component and tricuspid component, and it causes the first heart sound. And that is the end of diastole and the beginning of systole. So the first heart sound corresponds to the beginning of systole or the end of the diastole. Usually it is single, and it is usually a high-pitched one. But then sometimes you can hear the splitting of the first sound also, especially in patients with right bundle branch block, where the splitting of the first sound can be easily made out. And when there are two components around the first heart sound, you always get confusion whether it is a S4, S1, or whether it is a S1 and systolic click. Important to remember that S4 is a low-pitched sound, whereas both components of the M1 and T1 are all high-pitched. The second thing is that the T1, that the tricuspid component of the first heart sound, it is high-pitched, but it is very localized to the tricuspid area. Whereas the systolic click of a mitral valve collapse is a high-pitched one, but is very widely heard. Sometimes it is so loud that you can also hear without a stethoscope. So first heart sound is basically, although when we hear it, most of the time it is only single second sound. But in conditions characterized by right bundle branch block, the first heart sound can be split and can cause confusion. What is the second sound, and which I have already alluded to. Can I have the next? Okay, intensity of the first heart sound is influenced by various factors, electrical factors, mechanical factors, structural factors, which I will enlighten you as we go along. Can I have the next slide? So what is the normal intensity of the S1? How do you teach that? So normally when you auscultate over the apex region, the first sound is always louder than the second heart sound. And the same is the case at the lower sternum. So if the first heart sound is less intense than second heart sound at the apex, assuming that the second heart sound is normal, then probably there is some structural abnormality, or there is a reason for the first sound to be less intense. We'll come to that. So intensity of what is the normal intensity of the first heart sound? So you auscultate over the apical area. S1 is the loudest of all the sounds heard there. If it is less louder than the S2, then it is a less intensity or reduced intensity. Normally, M1 is louder than tricuspid 1 component. So it is important to remember these normal values so that abnormal things can be recognized much easier way. Can I have the next slide? So when is the first heart sound very loud? The classical example is in a patient with mitral stenosis. And to some extent, tricuspid stenosis is very rare, but almost about 10 to 15% of the rheumatic heart diseases will have an associated tricuspid stenosis. And the loud component may be M1, it may be loud component may be T1. It can also be due to increased transvalvular flow. For example, in patients with post-tricuspid shock, there's a lot of flow. With tricuspid shunt, like a left to right shunt at the atrial level, the tricuspid component of the first heart. It's important to remember that if you're diagnosing a patient with AHD and then you don't find that
Dr. Desagar, your voice is not very clear. If you can just,
Yeah, okay. Are you able to hear me now?
Yes, sir, better now.
Yeah, okay. So basically now it is not only influenced by the AV valve pathology, intensity of the first heart sound, but also influenced by the PR interval and the electrocardiogram. The shorter the PR interval, the louder is the first heart sound. The longer the PR interval, the softer is the first heart sound. So there are some.
Hello, sir, you are not audible.
All this time it was audible, no? Am I audible now?
if you can switch off your video, sir, and then you can, and that will be better.
No, I have switched off the video. I'm not.
Now it is also off. Now please go ahead, sir.
Okay. So the intensity of the first heart sound is influenced by structural integrity of the atrioventricular walls, the amount of flow that goes to the atrioventricular walls, and the electrical activity, especially the PR interval, and finally the status of the ventricle. If the ventricle is good or normal with the normal ejection fraction, that is dP by dt, or rate of change of pressure is high, then the first heart sound or the velocity of the movement of the leaflets will also be high, and that causes a very loud first heart sound. So there is more than one factor that contributes. This is more than one cardiac factor that contributes to the intensity of the first heart sound. Can I have the next slide? Yeah. When is the first heart sound decreases in intensity? For example, if it is a calcific or a fibrosed anterior leaflet of the mitral wall in a mitral stenosis, obviously the first heart sound will be low pitched and it is very dull. That is an indication that the valve is structurally seriously abnormal, and it's not a good case for any intervention of the valve, either catheter based or a closed mitral valve waterway. Or sometimes the first heart sound is softer, like in mitral regurgitation, because of lack of opposition of the leaflets. There is a space between the leaflets that is causing the what we call leakage of the wall, and it is this lack of opposition of the leaflets that causes a soft first heart sound. And finally, if the AV valve is closed prematurely, like in acute severe aortic, there is a rise in the
हेलो दयासागर सर, आपके वहाँ से कुछ नॉइज
Hello?
Yes, sir. Speak loudly, sir.
I've been speaking as usual, you know. Are you able to hear me properly now?
Yes, sir. Yes, sir.
So hand movement is causing some problems, or आप just voice को आप रखिए. That's all.
Uh-huh. Yeah, I'm very close to the iPad only, so that I can't. Usually, I don't have any problem with this voice anyway.
Now it is good.
Anyway, so if the AV valve is prematurely closed, like in acute severe AR, that means even before the onset of the ventricular systole, the AV valve is closed because of the rise in the end diastolic pressure of the left ventricle as a consequence of severe AR. The first heart sound will be softer. And that is an indication of a premature closure of the mitral valve, and that it generally indicates that is a severe AR, acute severe AR. The same thing also happens if the PR interval is prolonged, that is first degree AV block. If the PR interval is 0.2, more than 0.2, that is 0.24, 0.28 seconds, then the leaflets would have floated all the way back to the closing position, and they make less noise. That's why the first heart sound is softer whenever there is a PR interval is prolonged. Can I have the next slide, please? Okay, so we have discussed about what we call S1 normal intensity, decreased intensity, increased intensity. Now we are going to discuss about S1, wherein the intensity of the S1 is varying over a longer cycle length. For example, in atrial fibrillation, with varying cycle length, that is varying RR interval, there will be a variation in the intensity of the first heart sound. This is important to remember that. And if the pulse is irregular and varying intensity of the first heart sound, then probably it is an atrial fibrillation with varying RR cycle length. If the pulse is regular, but then regular but slow, for example, around 50 or 54, but then there is varying intensity of the first heart sound, it is a sign of a AV dissociation, which is a hallmark of the complete heart block. So bradycardia, coupled with varying intensity of the first heart sound, suspect there may be an underlying complete heart block with varying PR interval. So this variation in the intensity of the first heart sound is influenced by the position of the leaflet of the mitral valve at the onset of the ventricular contraction. So since the PR interval is varying, so there will be a different position of the mitral leaflets just before the onset of the ventricular contraction. Now the corollary of that is, suppose if the patient has got atrial fibrillation, but the variation in the intensity of the first heart sound is less, or practically there is no variation, then you should suspect the patient might be having an underlying mitral stenosis. This is basically because the mitral valve is kept open during the entire diastole because of the high LA pressure. And this open mitral valve, when it closes, it moves through a greater arc of distance, and that causes a loud first heart sound. So the intensity of the first heart sound, if it is not varying in a patient with atrial fibrillation with varying cycle length, suspect that the patient might be having an underlying mitral valve disease. Can I have the next slide? Now coming to second heart sound. Second heart sound is like the first heart sound. Second heart sound is due to closure of the semilunar valves. So there are two semilunar valves. So both of them produce, each one of them produces one sound, what we call the aortic valve producing a second heart sound, what we call A2 component of the second heart sound. And the pulmonary valve produces another sound called P2. So if you are hearing two components of the second heart sound, that means there are two semilunar valves are present. This has got a very high significance, especially when you are dealing with congenital heart diseases. Suppose if two heart sounds are clearly heard in a congenital heart disease, that means there are two semilunar valves normal. So the patient does not have truncus arteriosus, where the only one semilunar valve is there, but the patient does not have pulmonary atresia or aortic atresia. So there are, if two components of the second heart sounds are heard, that means there are two functionally normal semilunar valves. Each one, normally, aortic valve closes at a higher pressure than the pulmonary valve. The mean aortic pressure under normal circumstances is about 60 to 70 millimeters of mercury. Mark the word mean aortic pressure. It's not diastolic pressure. And the mean pulmonary artery pressure is usually around 14 to 20 millimeters of mercury. So aortic valve is closing at a higher pressure as compared to pulmonary valve. So aortic valve makes a louder noise as compared to pulmonary valve. And this is for this reason that aortic component of the second heart sound is heard widely over the pericardium as compared to pulmonary component of the second heart sound, which is often localized only to the pulmonary area. So P2 is heard only in pulmonic area. That is the second left interspace. If it is heard beyond that area, for example, if it is heard at the apical area also, that is apical area, both A2 and P2 are heard, that means there is pulmonary hypertension. That's a reasonably good, reliable sign of a pulmonary hypertension, P2 being loud. So that is the criteria we take when we say P2 is loud, means P2 is heard at the apex. The second criteria to say that P2 is loud is P2 is as intense as A2. Sometimes P2 can be louder than A2. That's a bit unusual, but it can happen. But the only exception to this rule, that when P2 is heard at the apex indicating pulmonary hypertension, then the only exception to that rule is in patients with ostium secundum atrial septal defects. The P2 can be heard at the apex, even in patients not having pulmonary arterial hypertension. So that is an exception. So it is important that you identify both the components of the second heart sound, A2 and P2, A2 occurring earlier and P2 occurring later. It is not only important to recognize that there are two components, it is also important to remember or to know or to evaluate what is the response of the second heart sound to normal respiratory cycle. Normally, during inspiration, there is an increase in the venous return to the right side of the heart. So the ejection time of the right ventricle increases. Consequently, the P2 moves away, or P2 goes beyond the usual length. Or to put it in a more technical language, the QP2 interval, that is from the Q of the QRS complex on the electrocardiogram to the onset of the pulmonic component, that is P2, that interval gets prolonged during inspiration under normal circumstances. By the same token, what happens during inspiration is there is expansion of the lungs, there is increase in the capacity of the pulmonary vasculature, and that's why that increased capacity of the pulmonary vasculature holds the blood within the pulmonary vasculature and thus causes a decrease in the left atrial venous return. So the QA2 occurs earlier. So the split of the second heart sound that occurs during normal inspiration is mostly contributed by prolongation of the QP2. To some extent, It is also due to shortening of the QA2. So this is important. So two components are heard. Evaluate the intensity, evaluate the behavior of the second heart sound, two components, in response to respiration. Can I have the next slide? So how do we evaluate at the bedside? So normally what happens is, you go back, yeah. Normally at the bedside, you're supposed to listen or you're supposed to appreciate the split during inspiration, and the second sound becomes single during expiration. Okay, so how do we evaluate the second heart sound at the bedside? So the starting point should be evaluate the status of the second heart sound in expiration. If during expiration the second heart sound is single, that means A2, P2 are fused, and you feel that is only one component, that is normal. But if there's an audible expiratory splitting of the second heart sound is present, that is definitely abnormal. Then comes, how do you evaluate further? So if you find audible expiratory splitting of the second heart sound, then you need to evaluate what is the nature of the split during inspiration. If during inspiration it is single, during expiration it is split, then it is reverse of normal, what we call paradoxical split. That's a bit rare compared to what we call wide splitting of the second heart sound. That means the second heart sound is split in both phases of respiration. Okay, so there is a wide splitting. So audible expiratory split of the second heart sound is always abnormal and calls for further evaluation. Then only you look at inspiration. So concentrate first on what is the nature of the splitting of the second heart sound in expiration. Okay, can I have the next slide? Yeah, so what we call in paradoxical splitting, it is reverse of normal. So in paradoxical splitting, there is a splitting of the second heart sound during expiration and single during inspiration. So the commonest cause for the paradoxical splitting is LVOT obstruction. That is left ventricular outflow tract obstruction. Be it dynamic obstruction like a hypertrophic obstructive cardiomyopathy, or a valvular aortic stenosis like in a bicuspid aortic valve with severe aortic stenosis. But then there are other non-hemodynamic causes of paradoxical splitting, that is due to left bundle branch block. This is due to delayed activation of the left ventricle that moves the entire spectrum of the left ventricular hemodynamics to the right. So both of them overlap. So one is electrical abnormality, other one is a hemodynamic abnormality that can cause this paradoxical splitting of the second heart sound. Can I have the next slide? Now this wide splitting of the second sound is a very important concept. Students often mistake wide splitting as the interval between the A2 and P2. I just want to emphasize that this does not represent or does not refer to the interval between A2 and P2. It is the behavior of the second heart sound to respiration. We call it as wide splitting. If it is split in both phases of respiration, that means it is split in inspiration, it is split in expiration, then we call it as a wide splitting of the second heart sound at the bedside. We're not talking about phonocardiography now. We're talking about bedside evaluation of the splitting of the second heart sound. And if second heart sound is split in both phases of respiration, inspiration as well as expiration, we say it is a wide splitting. There are two types of wide splitting is there. One is wide split, but variable split. It is split in both phases of respiration. But the split is more wider during inspiration and less wider during expiration. So we call it as a widely split but variable split. Classical example is right bundle branch block. Now you can have a wide split, but fixed split. That means it is split in both phases of respiration. A2, P2 can be appreciated in inspiration and also in expiration. And the interval between A2 and P2 is almost the same in both phases of respiration. So we say it is wide and fixed split. That is classical of ostium secundum atrial septal defect. Now there are other causes of a wide split. For example, if there's a pulmonic stenosis, valvular stenosis, the RV ejection period is very much prolonged. There, the P2 is not only delayed, but is also softer in intensity. So there are, just like LVB causing abnormality like paradoxical split, RBB can also cause delayed P2 because of delayed activation of the RV. So the splitting of the second heart sound plays a very crucial role both in evaluating the normality or the abnormality of the cardiovascular system, especially congenital heart diseases. It is also useful in pulmonary hypertensions. It is also useful in evaluating the left to right shunts. For example, in atrial septal defect, the second heart sound is split, wide, and fixed. In VSD, the second heart sound is generally normally split in the absence of pulmonary hypertension. And in PDA, the second heart sound is paradoxically split. It is paradoxically split because the left ventricle is selectively overloaded because of left to right shunt. So at the bedside, if you find there's a left to right shunt, evaluating the second heart sound will give you some idea about the level of the shunt. And it not only gives you the level of the shunt, it also tells you whether pulmonary hypertension is present or not present by evaluating the intensity of P2 and A2, both relative intensities and absolute intensities. Can I have the next slide? So intensity of the second heart sound. A2 intensity, we have already discussed about in the previous slide, but its intensity can be decreased also, especially in valvular pathology. That is, for example, in aortic stenosis, there's a long systolic murmur, crescendo, decrescendo, late peaking with a soft A2. Recently, we have had one patient wherein the echocardiographer and other people have said it is severe aortic valve stenosis. Examination revealed that A2 was normal in intensity. So you can never have a valvular aortic stenosis with a normal aortic second sound. On re-evaluation of the echo, it revealed that there was a subvalvular membrane in this patient of 16 years who came with symptoms of LVOT obstruction. So sometimes clinical examination, you have to integrate your clinical findings with the laboratory findings. Look at them individually. If the second heart sound is normal intensity in a patient who otherwise has aortic stenosis by all other criteria, then the level of obstruction is not at the level of the aortic wall. It may be either subvalvular or it may be supravalvular. It may be a fixed obstruction. It may be a dynamic obstruction like hypertrophic obstructive cardiomyopathy. So still there is a lot of relevance of the clinical cardiology at the bedside. So the loudness of A2 is usually what we call in hypertension with a very elevated systolic blood pressure and diastolic blood pressure. But it's important to remember that A2 can be loud even in the absence of hypertension, like when there is aortic aneurysm, what we call tambour-like quality of the second heart sound. It's something like as though you're tapping a tabla. It makes a peculiar noise, what they call tambour type. It is very classical of a dilated ascending aorta. Now here again, if the patient has got aortic regurgitation and if the A2 is softer, then the pathology of the aortic regurgitation is a valvular pathology. On the contrary, the patient has got aortic regurgitation with A2 being very loud, then you need to think that the pathology is not in the valve or leaflets, but the pathology is in the ascending aorta, which is dilated. More so if you hear the murmur of early diastolic murmur better or equally well on the right sternal edge. So clinical medicine, you need to apply them at the bedside to get the maximum out of it. Now P2, as I said, when do you say P2 is loud? When it is heard beyond the normal pulmonary area. Generally, we say if P2 is heard well at the apex, then the P2 is loud. Or if the P2 is as loud as A2, then also we say it is P2 is loud. Loud P2 again is a reflection of the pressure at which it is closing. So it is a reflection of pulmonary hypertension. It is very rare to have idiopathic dilatation of the pulmonary artery, but there the pulmonary second sound is not very loud. Pulmonary second sound is normal in intensity, certainly not decreased. Can I have the next slide? Okay, this is the graphic display of this second heart sound and how you evaluate. You see the top one, expiration and inspiration. So normally you need to start with expiration. What is the nature of this second heart sound? In expiration. Normally, as you see, there is overlap of green bar or the red bar. And both are fused, A2 and P2 are fused, and second sound appears like a single second heart sound. Onto your right side during inspiration, there is separation of the two components, A2 and P2, consequent to increase in the preload on the right side and a decrease in the preload on the left side. So that causes the thing. So same way, paradoxical split is the reverse of the normal, that is split in expiration, single in inspiration, and fixed split is split in both phases of respiration. So these are all important things to evaluate that will give you some idea about the hemodynamics, both of the right side as well as the left side. Can I have the next slide? Now, so far we have discussed only about first sound and second sound. Third sound. Third heart sound for the adults, as far as since we are all practicing adult cardiology, third heart sound in an adult is going to be abnormal. It is what we call there's a low pitched sound. It occurs somewhere in the mid diastole. The interval between S2 and S3 is about 100 to 150 milliseconds. It is much wider than the second heart sound, much farther away. It's almost in the midway in diastole that you feel the third heart sound. If you see if you recall the various intervals of diastole, starting with isometric relaxation, following that you get a rapid filling, followed by slow filling, followed by diastasis, followed by atrial contraction. It is at the end of the rapid filling that you get a third heart sound. It is important to remember that one of the important criteria for development of a third heart sound is ability to have a rapid filling of the left ventricle. This rapid filling of the ventricle causes tension of the cardiac tendonae during the expansion of the LV. The vibration of this cardiac tendonae causes the third heart sound. What are the hemodynamic equivalents of a third heart sound? Hemodynamically speaking, elevated LA pressure. Third heart sound means elevated LA pressure, left heart failure. It is as simple as that. So elevated, normally LA pressure is about 10 to 12 millimeters of mercury, but in patient with third heart sound, it may be something like 18 to 20 millimeters of mercury. The echo equivalents of the elevated LA pressure, that is E by A ratio more than 2:1. Deceleration time of the E wave is shorter, about 130 milliseconds. And the IVRT is short, about 60 milliseconds. These are all the very characteristics of echo Doppler. But at the bedside, third heart sound means elevated LA pressure. And in an adult, it's always abnormal. Can I have the next slide? Okay. You just skip over this slide. Next one. Yeah. Having said that third heart sound in an adult is abnormal, it has been reported that third heart sound can be normal in very young persons under the age of 16, 18, 20. Okay? This is because of vigorous ventricular relaxation. And if you see the tissue Doppler mitral annulus E wave velocity, it is much, what do you call, prominent. E wave velocity in these patients will be something like a 10 centimeters to 12 centimeters as compared to a normal person of 6 to 8 centimeters per second. So E wave velocity in these patients is very high. It's an indication of the vigorous active ventricular relaxation. It is this vigorous active ventricular relaxation that causes or that sucks the blood into the left ventricle, and it is this rapid filling of the left ventricle that causes third heart sound. So third heart sound is often said that beyond the age of 20, abnormal. Under the age of 20, probably you need to consider the coexisting cardiac conditions before you decide whether it is physiological or pathological. Third heart sound can not only occur on the left ventricle, it can also occur on the right side. Can we differentiate a right ventricular third heart sound from a left ventricular third heart sound? Answer is yes. If it is better heard at the apex, it is left ventricular third heart sound. If it is heard better at the lower end of the sternum, it is the RV third sound. If it is becoming more prominent during inspiration, it is probably an RVS3 and not a LVS3. LVS3 is more often than not is better palpable than audible. So that's one of the important things. If you're able to palpate a third heart sound at the apex, you cannot say a palpable LVS3 and audible RVS3. That's not possible. Can I have the next slide? Now, something similar to third heart sound, you have got another additional sound that can occur in constrictive pericarditis, what we call pericardial knock. Its timing is something like similar to S3, except that it occurs slightly earlier than a third heart sound. And it is much higher pitched as compared to a third heart sound. It is easily audible. And compared to S3, it is a much higher pitch. This is basically because in constrictive pericarditis, almost 90% of the filling of the left ventricle occurs in the first one-third of diastole. No flow in mid-diastole, no flow in late diastole. This is what we call classically a square root pattern of ventricular pressure tracer. So since all the filling occurs rapidly and in the first one-third of diastole, that causes this knock, what we call pericardial knock. And it is supposed to be characteristic of constrictive pericarditis. Can I have the next slide? Now, importance of S3 in valvular heart disease. Does S3 always mean an LV dysfunction in valvular heart diseases? The answer is no. Presence of S3 in aortic regurgitation is specific for LV dysfunction. But S3 in mitral regurgitation is a sign of severe mitral regurgitation. It is a sign of a severity of the mitral regurgitation. It is not a sign of LV dysfunction in mitral regurgitation. So, interpretation of the S3 in valvular heart disease, you need to know what type of valvular heart disease the patient has. So, S3 in AR is LVF, S3 in MR is severe MR, and it is not due to an LV dysfunction. It is important to just to remember that. Can I have the next slide? S3 in valvular heart disease, can you just go forward? One more slide. Yeah, okay. So S3 and S4 hemodynamics in valvular heart diseases. You need to remember one thing. This S3 and S4, for it to occur, there must be a free communication between the LA and LV. The same way, there must be a free communication between RA and RV to happen on the right side. Suppose if you say that S3 is present in left ventricle, then you can practically rule out additional mitral stenosis. If there is a significant mitral stenosis, you will never get a rapid filling of the left ventricle. So S3 presence you cannot say S3, LV-S3 is present and a mitral stenosis is tight. Both are not compatible. You can have S3 over the left ventricle and can have a severe MR or a severe AR. But you cannot have an S3 over the left ventricle with mitral valve obstruction. Same thing holds true. You cannot have RV-S3 in the presence of a severe tricuspid stenosis. Same way, S4 is due to atrial contraction. S4 is due to atrial contraction means the patient is in sinus rhythm. A palpable S4 is an indication that the patient is in sinus rhythm, just as the presence of an A wave in the jugular vein is an indicator of the sinus rhythm. It also indicates that there is a free communication between the atria and ventricles. That force with which atrial contraction has to be transmitted freely to the ventricle to develop these vibrations. So you cannot get S4 in a patient who is in atrial fibrillation. Neither you can get a palpable S4 in a patient who has got a mitral stenosis or a tricuspid stenosis. So these are the implications of a third sound, fourth sound in a patient. Can you go back previous slide, please? Now, unlike the third heart sound, which indicates a pump dysfunction, the fourth heart sound reflects the diastolic dysfunction. That third sound reflects the systolic dysfunction. Fourth sound reflects the diastolic dysfunction. There is an abnormally prolonged ventricular relaxation during the early period. So the ventricle tries to compensate, or the heart body tries to compensate the filling of the LV by the vigorous contraction of the left atrium in the terminal portion of the diastole. And it is this vigorous contraction of the atrium that causes the fourth heart sound. And that has got a lot of implications. So if you find a fourth heart sound, patient is in sinus rhythm and no mitral stenosis. And by and large, fourth heart sound patients have normal LA pressure. They may have slightly elevated LV and diastolic pressure. It often indicates a stiff ventricle as a consequence of hypertrophied ventricle, like in hypertension for LV, or a pulmonary hypertension for the RV, or a pulmonic stenosis causing severe RVH. These are all the, so fourth heart sound indicates a diastolic dysfunction, just as a third heart sound indicates a systolic dysfunction. Can I have the next slide, please? Next, yeah, okay. Now, one of the important additional sounds which is abnormal is the opening snap. Opening snap is a consequence of abnormal anterior leaflet of the mitral wall. Remember, although the name opening snap refers to opening of the mitral wall, that the sound does not occur at the onset of the opening of the mitral leaflet. The sound occurs at the end of the full opening. So it consists of mitral wall excursion time, which in turn is a reflection of the MV mitral wall mobility, apart from isovolumic relaxation time. So the S2 OS interval, which is often used as a marker for severity of the mitral stenosis, S2 OS interval consists of two intervals. One is isovolumic relaxation period that follows the second heart sound. Second one is the mitral wall excursion time, or the time taken by the mitral wall to reach the full opening of the mitral leaflet from the beginning to the end of the opening. So it is this excursion time, what we call. That excursion time is influenced by mitral wall mobility. So your S2 OS interval is not only influenced by the severity of the mitral wall, but is also influenced by the mitral valve pathology. Suppose if the valve is fibrotic, it may take a longer time to reach the tip or to reach the end of the diastole. So it may be S2 OS interval may be delayed, even though the mitral stenosis might be tight. So there are some pitfalls in evaluating or in using S2 OS interval as a marker of severity of mitral stenosis. Barring those one or two caveats, in general, the shorter the S2OS interval, the tighter is the mitral stenosis. And the longer the S2OS interval, the milder is the mitral stenosis. For example, if the S2OS interval is less than 70 milliseconds, it's a tight mitral stenosis. If the S2OS interval is more than 100 milliseconds, it's a mild MS. It is equally important to remember that opening snap by and large is a high-pitched sound. It's a very sharp sound. And it is heard in most of the areas of pericardium. So it's a high-pitched sound heard in a variable areas, not localized only to the mitral valve area. So when you find when the valve is abnormal, for example, fibrosed and calcified, the acoustic characteristics of the opening snap changes. From being a high-pitched sound, it becomes a low-pitched, dull sound. That should indicate that the mitral valve is badly damaged, fibrosed, probably calcified, and is not a good, valve to be interfered with the balloon valvotomy. Can I have the next slide? No, I think you have skipped one slide. Can you just go back? Yeah. Now, when you hear two sounds soon after a second heart sound, we are often worried whether it is a widely split second heart sound or whether it is a second heart sound and then an opening snap, especially at the apical region. So how do we differentiate that? Whether it is S2OS or it is a split second sound, that is A2P2. Now, the simplest thing is to make the patient stand up. If after standing, if the interval between the two sounds becomes closer, then it is, somebody says, okay, there are no audience who can respond. So if the split becomes narrower, then it is A2P2. On the contrary, if the interval between the two sounds becomes wider, then it is S2 and opening snap. The interval of S2OS becomes wider on standing, basically because there is pooling of the blood in the lower half of the body that causes a reduced venous return to the right side followed by left side. It is this fall in the preload that causes a decrease in the LA pressure, and this decreased LA pressure causes widening of the S2OS interval. Can I have the next slide? Something closely similar to mitral stenosis, occasionally you do see myxomas. And that myxoma, sometimes by clinical examination, you can suspect it. Unlike the opening snap of rheumatic mitral valve disease, the tumor plop, that is the noise it makes when the myxoma is prolapsing from the LA across the mitral valve into the LV, that noise is called tumor plop. This tumor plop is a low-pitched sound in contrast to the opening snap, which is a high-pitched sound. But by and large, this tumor plop is followed by an MDM, and occasionally may also be followed by a mitral regurgitation as well. So this tumor plop, unlike the opening snap, is a low-pitched sound, whereas opening snap is a high-pitched sound. Next slide, please. Now we come to so far about the diastolic noises. Now we are going to talk about systolic additional sounds, systolic clicks. So systolic clicks can occur either because of the abnormality of the atrioventricular valves, like mitral valve prolapse syndrome or a tricuspid valve prolapse syndrome. It can also occur as a consequence of abnormality of the semilunar valves, like a badly or stenotic aortic valve or a stenotic pulmonary valve, where the opening of these morphologically abnormal semilunar valve causes the click. So it can be aortic click, it can be pulmonary click. It can not only occur, these clicks can not only occur because of the valvular abnormalities, it can also be occur because of vascular abnormalities, wherein the aorta is dilated or pulmonary artery is dilated. The actual stretch of the dilated roots of the major vessels causes a click. These clicks are called vascular clicks. Unlike the valvular clicks, the vascular clicks do not change with respiration. Apart from these valvular clicks and vascular clicks, there are also some other clicks are seen, which are labeled in the literature as pseudo clicks. I'm not sure why the name pseudo click has been given. Basically, because these clicks are not as high pitched as the usual clicks. These pseudo clicks can occur in hypertrophic obstructive cardiomyopathy, IVS aneurysms, and IAS aneurysms, and very rarely because of introduction of the pacemaker leads across the tricuspid wall. Can I have the next slide? So these systolic clicks are due to wall prolapse. The timing of the click varies. The timing of the click corresponds to the peak prolapse period of the respective AV wall. Usually they are high-pitched, but they are widely audible. And if it is coming from the tricuspid side, it does vary with the respiration because of changing preloads secondary to respiration. That the more severe the prolapse, the more earlier the prolapse, the earlier will be the click. So the click can be early click, early systolic click. It can be mid systolic click. It can be late systolic click with very short murmur. Although most of the time these clicks are single, sometimes these clicks can be multiple, what we call salvos of clicks. There may be 2 or 3 clicks at the same time, one following the other. That's very typical of the Barlow syndrome. Now, when should you suspect? For example, if the patient with mitral regurgitation has got a loud S1, which you don't expect normally. So if the S1 is loud, what looks like a S1, loud S1, is basically because the click has fused with the first heart sound, and that is causing a loud S1. So you should suspect that the MR is due to a severe mitral valve prolapse. Can I have the next slide? Now, these are the ejection sound, aortic ejection sound and pulmonary ejection sound. It is important to remember these things. Pulmonary ejection sound varies with respiration. It is actually pulmonary ejection sound becomes softer during inspiration. Remember, this is the only right-sided event that becomes less intense as compared to all other right-sided events, which become more pronounced during inspiration. So pulmonary ejection sound becomes less intense during inspiration. Whereas aortic ejection sound does not vary with respiration. More importantly, it is heard very widely all over the pericardium. Whereas pulmonary click, pulmonary ejection valvular click, is very localized only to the pulmonary area. Can I have the next slide? Now there are other sounds, what we call eddy sounds. These sounds are seen only in the patent ductus arteriosus. These are all multiple clicks that occur in the late systole or early diastole. And these are supposed to be due to clash of the 2 jets, one coming from the RVOT into the PA, clashing with the jet that is coming from the aorta via the PDA into the pulmonary artery. It is this clash of 2 jets that produces these abnormal sounds, what we are calling as eddy sounds. So these can be in the later part of systole or early diastole. What is the importance? Importance is if the patient has got a continuous murmur with eddy sounds present, then it can't be anything else other than ductus arteriosus. Can I have the next slide? The pacemaker click has been reported, but not very frequently. There are 2 reasons are given. One is there is excessive motion of the leads across the tricuspid wall during the cardiac cycle that makes the noise. But more importantly, phonocardographically, they have documented that there is a mid-systolic click that occurs following a pacemaker spike. And this pacemaker spike has this electrical current of the pacemaker is sensed by the intercostal nerves, which causes contraction of the intercostal muscle. So this pacemaker click, according to many, is caused by the contraction of the intercostal muscle consequent to stimulation of the intercostal nerve by the pacemaker current. Can I have the next slide? Now, atrial septal aneurysms and ventricular septal aneurysms do occur, and it is being picked up more often than not by the 2D echocardiographers. And it has been documented that atrial septal aneurysm can also cause clicks, and these clicks are usually systolic clicks. Can I have the next slide? There is what we call pseudo click or a pseudo ejection click has been documented in hypertrophic obstructive cardiomyopathy. But unlike the other clicks, it is slightly a medium frequency or a low frequency. It seems to occur at the time where the SAM or the systolic anterior motion of the anterior leaflet touches the interventricular septum. It is supposed to be due to the impact of the AML to the septum, or some people feel it is due to deceleration of the blood flow in the LVOT consequent to the SAM that occurs during systole. Be that as it may, it is an additional sound that occurs in mid-systole, and it is slightly medium frequency or a low frequency, not in the usual frequency of a click. Can I have the next slide? Now, the click of IVS aneurysm is probably slightly important. So the patient has got a ventricular septal defect murmur, pansystolic murmur, plus there is an additional click that precedes the systolic murmur. That means the patient has got aneurysm of the interventricular septum. A patient with VSD with aneurysm of the interventricular septum has got a very good long-term prognosis, and they're likely to close spontaneously. So you're going to pick up some patients at the bedside. If you hear an aneurysm sound produced by the IVS aneurysms in a patient with VSD. Can I have the next slide? I think the last slide. No, finally, the prosthetic cardiac valves. Valve replacement has become a common surgery in our country, courtesy of rheumatic heart diseases. Now we are getting more and more degenerative valve disease of aortic valve. It is important to remember that most of these prosthetic cardiac valves, what we are going to put in many of the centers, because of the younger age of the patients, most of them are mechanical valves. Very few are the biological valves. It is important to remember that mechanical prosthetic cardiac valves behave exactly like the God-given native valves, either in the AV valve position or in the semilunar valve position. So these valve leaflets, these prosthetic cardiac valves, either in aortic position or in the mitral position, they make noises only when they close. So M1 is the mechanical, or a what do you call a high frequency click occurring in the setting of around the first sound. It has to be a mitral mechanical prosthesis. On the contrary, if you find a high frequency A2 component, then it is mechanical aortic prosthesis. These, what do you call, disc valves, do not produce any sounds during closure. During closure only they will not produce sounds during opening. Sorry. So the prosthetic valves behave exactly like the native valves. Native valves make noise only when they close. They don't make noise when they open. So these prosthetic valves also make noises only when they close, and they don't make any noise when they open. Like, for example, they don't get any ejection click in the aortic position, nor you can get any opening snap in mitral position. The only exception to this rule has been a ball and cage valve, which is now outdated and nobody seems to use it, called Starr-Edwards valve, which used to make noise both during opening as well as closing. Fortunately, this valve is not in use as on today. Can I have the next slide? I think that's the last slide. So basically, the heart sounds both normal and abnormal. Evaluation is important. It does tell you about the anatomy in the sense that there are two semilunar valves. And the status of the walls also, they will tell you if the intensity is normal. It will also tell us about systolic function of the ventricles and diastolic function of the ventricles. It can also localize the level of obstruction in cases of semilunar walls if there is a valvular click. And it can also differentiate whether the pathology is on the right side or on the left side. If these sounds are becoming more prominent during inspiration, they are coming on the right side. If they are better heard during expiration, they are coming from the left side. Thank you, ladies and gentlemen, for your attention.
Thank you, sir. Thank you so much for this nice presentation, and probably this will at least stimulate the new residents for this reading about these heart sounds, because this was a very simple and brief overview, and you can go into the further details of these topic. And I'm sorry for the little goof up that happened in the beginning. Dr. Sumod, if you have any questions, then we can have as we close.
Sure.
Thank you, sir, for that way, presentation that was very simple and easy to understand. A few clarifications.
Yeah.
Sir, you had told that it is very easy to make out what is systole and diastole when the heart rate is low, like 70.
Yes,
But
yes,
when it becomes, on the higher side,
yeah, 100.
systole and diastolic differentiation becomes difficult. So, what are some tips to,
Yeah, at that point of time, when the heart rate goes beyond 100, it becomes practically difficult to make out which is systole, which is diastole. So what I recommend is you palpate the carotid artery. The one that comes along with the upstroke of the carotid artery is systole. The one that comes after that is diastole. So we use carotid artery for timing of the events. And events that occur along with the upstroke of the carotid is systolic. And anything that are occurring other than that is diastolic.
Sir, many times, watching the respiration, timing with expiration, inspiration can become difficult, and it is often advised that, you should not ask the patient to take inspiration and hold it, or, expire and hold it. So, so how do
No. It is absolutely recommended that you examine the patient while the patient is breathing normally.
Yeah.
Don't ask him to take a deep breath. Don't ask him to hold the breath, all those things. You have to concentrate during expiration, whether you are able to hear both components of the second heart sound or not. If you are not able to hear, if you are hearing only one single second heart sound during expiration, then the second heart sound is normal. If there is audible expiratory split of the second heart sound, mark the word expiratory, then it is abnormal. You need to go further. If it is audible expiratory split is there, then you go into the inspiration. If it is split in inspiration, it is still normal, but wide and fixed, wide and variable. But if it is single in inspiration, then it is paradoxical.
what is the difference between the pitch and the loudness? Many times the high pitch sound can appear louder because of their quality. Pitch and loud.
From the what do you call sonographic point of view, the pitch refers to the frequency of the sound, and the intensity refers to the amplitude of the sound waves. So, but basically